CMDA Western New York. So make sure you head on out and participate in the potluck. No, I mean, that's our usual format, is to be at different locations and be able to share a meal together as we prepare for a meeting and prepare for a message or some challenges. But tonight we're on our own with our potluck. So maybe we'll start doing a recipe collection for these for future events. All right, so we are coming along here with folks that are joining now. While we're waiting on folks, I'm just going to go through a little bit of the structure. We've got a little bit different format than we'd normally be able to use, since we don't have the informality of being at someone's home. We're going to have a little bit of structure for the program this evening. We have 3 speakers that'll be going. I'm going to ask. I know there are going to be great questions that come up, and the temptation is going to be there to just pepper our speakers with questions in the order that they're going on through. But I'm going to ask that folks refrain doing any questions until all 3 of our speakers have had a chance to go, and then we'll open things on up to a Q&A session. What's that? How are we going to do the Q&A session? Excellent question. What we're going to do is we're going to use the chat function that's present here as our primary means of communicating, so we're not bumping on background noise and things like that. For the chat function, for those of you that are familiar with that, it's its usual place. For those of you that are not familiar with the chat function, if you drop down to the bottom bar, you may not be able to see it right away, but if you scroll down, you'll see a bottom bar pop up under Zoom. Click on the chat function there, and that'll open up the chat dialog box, and that'll give you an opportunity to enter on in your questions. And hopefully we won't miss any. They do pile up, they do stack up here in the background, but I think we'll do all right with that. All right, so we have all of you muted in the background, almost all of you that are muted in the background. There may be, our speakers may not be muted, so we're going to just give folks just a couple more minutes to drift on in. Many of you are already familiar with CMDA and CMDA of Western New York. For others of you, this is going to be a first encounter, and maybe you've been attracted by the topic here of the pandemic going to church, because that's something that all of us have been facing, not just in the workplace for those of us that are directly dealing with patients, but for those of you that are online that are pastors. We welcome you, and we know some of the things that you've been dealing with, because we've been hearing back from our own pastors about what exactly does this mean in terms of percent. How important are the masks that we're asking people to put on? Is it making a difference for people? All these sorts of questions are on out there. So CMDA is the Christian Medical and Dental Associations. We're the Western New York chapter of that, and we are comprised of physicians, dentists, but also a variety of other healthcare practitioners, including pharmacists like myself, chiropractors, physical therapists, OTs, all the full spectrum of healthcare providers that are in Western New York. For those of you that are not familiar with CMDA, I would strongly encourage you to head on out to our website, or if your preference is live with Facebook, we have a Facebook page there as well. Most of you have navigated on in through that or seen some links to that. What we'll be able to do, and this is where I'm waving off to Chris Sullivan, who's in his own studio, in his basement studio, broadcasting from there. Well, we have the capability to send people just a brief bit of contact information if they've been on this, or do we need to supply them with the URL to the web page at the live through the course of the program? From that,
yes to both.
Okay, great. So what we'll do is we'll send off to everybody just the URL, the click that you'll click to take you to the CMDA Western New York webpage, and as well as the information that you'll need for Facebook. Okay, let me just reach on over here and get some other things in place, just so we stay on time and move on through appropriately. I'd like to introduce our first speaker. John, this is your cue to get ready to go through your portion of the talk. John Crane, we are absolutely delighted to have him. He's a very long time CMDA Western New York member and part of the Leadership Council, but that's not the only reason that he's here tonight. He's also here because of his background in infectious diseases. He's a professor at the University of Buffalo School of Medicine in the Division of Infectious Diseases. And he's been a man that's in great demand lately. You may have seen him on some of the TV interview clips that have been out there addressing everything that people want to know about COVID-19. John, I'm going to turn this on over to you to give us a setting, to get the setting of how COVID-19 from a medical perspective is impacting the church and all of our lives.
Okay, thank you, Ed. And I'm going to try to see if I can do my share screen function now with the PowerPoint share. And I don't see it yet. Didn't really work. Let me go back. Share screen. PowerPoint presentation. Share. I just see
John, I think you are
white.
sharing. Yeah, I think you're sharing the whiteboard. So when you click share screen, you should see a bunch of different options, and it automatically defaults to the whiteboard. And so
I
you'll
see.
have to
Okay,
click
it says
on
advanced sharing. Advanced sharing options. Okay, no, click out of that. Go back. Yeah, there are different options that come up. Whiteboard is, yeah, okay. Now,
there we go. You got
PowerPoint is, okay, there we go.
There you go. Just click
there,
on.
Yep. Okay, and I'm gonna do it this way, play from current slide.
Perfect.
And I'm also going to see if I can get a laser pointer so that I can wiggle my mouse and you can see it as a little red dot.
John, that's
so yes, welcome. Did you know that trick, that little laser red dot trick?
John, I've learned something already.
Yeah,
You're just on your title slide and I've taken something away from this.
Well, that's good. We all learn little tricks. There's lots of little features in Zoom, and it takes you a long time to learn all of them. So welcome to this meeting, our first CMDA. We're calling a fusion dinner, even though everybody was responsible for eating on their own at home. But in honor of a traditional fusion dinner, we made chili in the crock pot tonight. A typical, a popular item for people to bring to one of our real CMDA dinners where we would meet and have fellowship around the table. So yeah, the pandemic goes to church, and boy, it's been a wild year of 2020. This is just posted on Facebook today by my friend Bob Hayes, whose wife Kathy has gone with us to Honduras about more than a dozen times. And he said, "Oh, I put up my Christmas tree." I don't think this is really his Christmas tree. I think he found this picture file photo somewhere. But this is what people, this is pandemic humor for the holidays. Okay, so just as a little brief introduction to the virus itself. The name of the disease and the outbreak is called COVID-19. The technical name for the virus itself is SARS-CoV-2, but most people just call it COVID-19. And so I just wanted to emphasize that it's not just an infection of the lung, even though SARS stands for a severe acute respiratory syndrome. So just to summarize, multiple organs around the body are affected. In the brain, you can get stroke or mental confusion. It can affect your heart, causing viral myocarditis, which impairs your heart's ability to pump blood. It can affect the kidney with acute kidney failure or acute kidney injury or kidney failure, including severe enough to require dialysis. And this can be permanent kidney failure. The intestinal tract is affected in some people with diarrhea. Almost everybody with COVID has an increase in their liver function tests. It's a blood test that's routinely done. And of course, we already know about the lungs. That's what gets most attention. Viral pneumonia, and PTX is an abbreviation that stands for pneumothorax. And that's where your lung spontaneously develops a puncture and collapses. And that can occur from vigorous coughing as a result of the infection. And can also occur as a complication of long-term ventilation or barotrauma from having high pressure air forced into your lungs by a ventilator machine. So these are all pretty serious and some of them life-threatening conditions. And then they didn't have good graphics for this, but other examples of what COVID can do to you are venous and arterial blood clots, including pulmonary embolism, where a blood clot breaks off and travels to your lungs, COVID toes and other skin manifestations. Children generally have milder courses of COVID, but even after they're done with it, they can flare up with this mysterious condition called multisystem inflammatory syndrome of children, or MISC. And then, as you probably heard, people who have recovered from COVID often suffer from psychological depression or brain fog, difficulty concentrating, and so on, which can be very bothersome for many weeks or months afterwards. And then other long-term persisting effects, which people are beginning to refer to as the long hauler syndrome. So just a little bit about the differences between COVID-19 and influenza. They are similar. They're both viral respiratory infections, both transmitted through the air, either by large droplets or by true aerosols. But there's quite a few differences between the two. First of all, the R naught. So that's the basic reproduction number, R with a little subscript 0. If you want to be sound fancy like an epidemiology professor, R naught is how they say it. And so the R naught number for influenza is average around 1.3. It has to be greater than 1 for a disease to propagate and to continue in a population. If it's less than 1, it will gradually dwindle away. COVID-19 in most average situations behaves as if it has a R naught number of between 2 and 2.5. Now, this R naught number is not solely a function of the virus itself, however, because human behavior affects how well the virus propagates. It's not just based on the virus's own DNA or RNA sequence. Okay, incubation time with the flu is it's shorter, 1 to 4 days. If a family member has flu and 4 days go by and you haven't caught it, then you probably won't. Notice that with COVID-19, it's much longer, up to 14 days, but most people develop it by about 7 days. 5 to 7 days is the peak onset time. Hospitalization rate, obviously much higher for COVID-19 than for influenza. And the case fatality rate is also much higher, at least 10 times higher, maybe 20 times higher than influenza during a bad flu year. And some years we have milder flu seasons. So quite a few differences between the two. So when people say, oh, it's just the same as the flu, that's not true. That's a falsehood that people are propagating, usually because of to try to assuage their own beliefs in some way. Okay, so transmission is not just coughing and sneezing. COVID-19 is so contagious, just ordinary breathing and ordinary talking is enough to transmit the virus. So a person does not have to cough on you or sneeze on you in order to give it to you. So those are the main way. The other way it can be transmitted is by direct contact, meaning like hugging, kissing, shaking hands, and so on. Those are also high-risk behaviors. Now we're going to introduce the concept of super spreaders, which has an influence on policy related to whether we can worship in the church congregations or not. So unlike influenza, in which everybody is about equally contagious. In COVID-19, some people are hardly contagious at all, and other people are highly contagious, and they're the ones that are called super spreaders. So about 10% of people with COVID-19 are responsible for between 70 to 80% of cases of transmission resulting in subsequent cases. So this small subset is responsible for a big amount of transmission. And here's just an example from an outbreak in Catawba County, North Carolina. And this was after a family picnic in which people did not wear masks. These are all the people in the family who caught COVID-19 from this family gathering. And this just shows that many of the people in this family, such as these orange and yellow ones at the top, did not transmit the virus to another soul. Same with some of these other people down here and so on. But then there were a few people, like this person, who transmitted it to 3 other people. This person transmitted it to 3. This person transmitted it to 3 others. This either the husband or the wife, not sure. This spousal couple transmitted it to 4 other people. So a few people are highly infectious and contagious to others, and then some people don't transmit it to anybody. So that makes it difficult for contact tracers and stuff to predict who's going to come down sick, but we have to take this into account. Here's another one that many people in the church world have heard about. High attack rate following exposure to COVID-19 at a choir practice in Skagit County, Washington. And this was at a Presbyterian church. They had 120 people show up for choir practice. So pretty big choir. We would love it if we had half that many people in the choir at our church. Also, the choir practice went on for 2.5 hours. At our church, I think people started getting restless after about 1.5 hours. And so this is a big choir, and they also practiced for a long time together. And here's the picture. There was one person who came to the choir practice. He wasn't feeling his normal well self, but he figured he needed to show up anyway, and he transmitted it to 87% of the other choir members in that choir. So it just shows you how transmissible it can be when you have a large group indoors and a highly infectious super spreader among those people. Okay, now people often ask about what is the role of inanimate objects, which in epidemiology speak are called fomites. So inanimate objects or fomites have often been overemphasized in the transmission of COVID. Examples of fomites are things like, now these are places that we do need to be worried about, where fomites have been or might have been involved in transmission, are things like blood pressure cuffs that have been used for weeks in the care of a COVID-19 patient, for example, someone in the ICU, glucometers used for rapid blood sugar testing, and other medical equipment. That obviously is somewhat dangerous and needs to be carefully cleaned if it can be done, or discarded between patients. Otherwise, though, fomites do not play as large of a role in the transmission as most people think. For example, clothing and textiles appear unlikely to be involved in the transmission of COVID-19. And this is quite to the contrary of the practice of a lot of medical practitioners, who often feel that they have to strip down to their underwear when they come home from work in a hospital. That's probably not necessary. But I remember back in the spring when we were first getting hit by COVID, a person posted on Facebook that on his way home from work, he saw one of his neighbors, who was a nurse, stripping down to her underwear on her side door, and carrying her clothes inside. He said, I closed my eyes, I covered my eyes because I didn't want to have a crash, because he knew this lady and she was a friend of his. But that was what people were doing in the beginning, feeling that they had to strip down either to their underwear or to completely naked before they could come into their house. And then they would have to immediately take their clothes to the washing machine and wash it immediately. And that was also probably unnecessary. It's probably a good idea, if you want to be careful, just to take your clothes off when you get home and put them in a plastic bag, and then do your laundry the way you normally would. Okay, now when schools and other institutions are hit by COVID, as a reflex, the administrators will often announce that they are going to perform a deep clean. And this seems to be intended to reassure the public they're doing everything that can be possibly done. The trouble is that sometimes they do this even when it makes no sense. For example, one of the school districts in our area had an outbreak in which 20 of the people involved were teachers. They were faculty. And so doing a deep clean of all the student lockers doesn't make any sense in that situation, because the teachers don't have a student locker, and they generally don't touch the lockers of the students. So going through this exercise doesn't make any sense. Instead of going through a deep clean, it would make more sense for the principals and the school administrators to conduct a deep dive to ascertain where the transmission is occurring and how to interrupt it. So, for example, in the faculty outbreak, even though the teachers were wearing masks in the classroom, they were having their coffee breaks and their lunch breaks together in the teachers' lounge with no masks on. So that's probably the area where the transmission occurred, not due to touching the door handles or the lockers in the hallway. Okay, so just a little summary of we do have a lot more therapeutic interventions that we can offer now for people with COVID. Of course, there's respiratory support of various different kinds. It could just be supplemental oxygen or high flow oxygen, including nasal BiPAP, and then all the way to being placed on mechanical ventilation. Anticoagulation is important because of the ability of this viral infection to trigger blood clotting around the body. And so anticoagulation is now routinely practiced. Convalescent plasma is also been given an emergency use authorization by the FDA. And this is taking the plasma from patients who have recovered from COVID-19 and administering it to people who now are suffering from acute infection with the virus, to try to give them antibodies against the virus. Remdesivir is an antiviral drug that you probably heard about. One of its main limitations is it has to be given IV. And it's usually given IV every day for 5 days. So it's pretty much limited to hospitalized patients. I've had several people calling asking for remdesivir who are outpatients, and it's just pretty impractical to do that. There was another landmark article that was published in The Lancet showing that dexamethasone, which is an anti-inflammatory steroid similar to cortisone, caused decreased mortality in people that were severely ill with COVID, either on the ventilator already or requiring supplemental oxygen. And then there's also a couple of different other experimental trials that are going on. One of them was just approved at the beginning of this week. It was a monoclonal antibody made by the Eli Lilly company against the COVID-19 spike protein. And the Regeneron company also makes a combination of 2 different monoclonal antibodies against that same spike protein. That's the antibody that President Trump received when he developed COVID-19. And the spike protein, if you probably know already, but in this little computer graphical design, the red bumps sticking out of the virus, those are the spike proteins. So they're very abundant and they're surface accessible, and they're quite immunogenic. Okay, so how can physicians advise their faith communities during the COVID-19 pandemic? Well, here was an article that came out by a group of doctors in Rochester, Minnesota. They all were professors at the Mayo Clinic. You see, there's people from different faith backgrounds. This man is a Muslim. Some of them were Christians, and some of them were Jewish. And they all talked about what they did in their home congregations to try to come up with a plan for worshiping and prayers during the spring portion of the COVID-19 outbreak. And so here's some of the differences between these faith communities. There were only 2 Jewish synagogues in Rochester, Minnesota, 4 mosques, but they have generally have a large population. And of course, there's many, usually many more Christian churches, but our congregations often tend to be smaller, and so on. So they gave their examples of the advice they gave to their congregations: no hugging and handshaking, use of sanitizer, wearing masks, distancing between people in the pews in their congregation, and so on. And then also just help to interpret medicalese jargon like flattening the curve and explaining things in more practical terms of what it actually means in the actual place where people are meeting to worship. And so they thought that since they were already members of their own congregations, that their congregations did respond to their advice rather than just being given to them by someone in the government. They worked through these together, and they came up with the plans that they were going to try to follow. And that's what most churches, I think, have done. Okay, now we were trying to figure out what we were going to do when this week, all of a sudden, we are placed into the orange zone, where we have less leeway in deciding what we want to do about church, because under the orange zone restrictions, which includes most of Erie County, New York, churches and houses of worship are limited to either 33% of capacity or 25 people, whichever is smaller. So that's a pretty small number of people allowed to gather together. And as a result, several church congregations have decided to abandon live in-person worship and to go to video or online worship format. And that's what our church is doing. Tomorrow, Sunday, will be our first time that we resume video worship service instead of live. And my pastor, Pastor Adam Miller Stubendick, will be coming on and talking and giving the pastor's perspective in a moment. So, and then also people ask, what about the vaccine? The very first doses of COVID-19 vaccine may start arriving in late December 2020. Remember that the first batches of vaccine, which are large batches, have all been purchased by the United States government. So they will be allocated however the government decides to do it. The drug companies will not be advertising these to the public. They won't be telling you, you won't be allowed to promote their product. Whatever vaccine the government sends us is what we'll get. As you probably know, if you've been following this, there's 2 vaccines that have already announced their preliminary results, and there's 2 or 3 others that are following closely behind. So the 2 that have announced is the one that the vaccine produced by Pfizer in collaboration with a German biotech company called BioNTech. And the second one that was just announced this week is from Moderna. Both of them are mRNA or messenger RNA vaccines. And people are saying, well, how do I get to pick which vaccine? What vaccine do you recommend that I get? Well, I don't think we're going to have any choice. Whatever the government sends us in Western New York is what we'll have. Your only choice will be whether you accept or refuse. I don't think you're going to be able to bargain and say, no, I want to hold out. I want the Moderna. Oh, I want the other one. Oh, I want the Johnson & Johnson, or I want the AstraZeneca vaccine. I don't think we're going to have that option. And even after we have the vaccine, it's going to take months before a high enough percentage of the population actually receives it to provide a protection in the population wide. So we will have to continue wearing masks, doing the social distancing, and all the other things that we've been doing for a long time after we start the vaccination program. The wearing of masks and the other protection things don't stop just because the first group of people are starting to get their vaccine. So the way we respond to the COVID-19 pandemic is a reflection of our own Christian faith. It's been very stressful for many people, but it's also an opportunity for ministry, because many people, especially people in the healthcare and medical field, who would normally not think about spiritual things, are now being forced to confront them. And we have an opportunity to share why we have hope, while so many others do not. So people are being forced to confront things like the possibility of their own mortality. Young doctors and nurses and physicians' assistants are having to write up a will in case that they should pass away from this infection. And that tends to focus the mind on what's going to happen to our soul after we depart this earth. So this is an opportunity for us to minister to our co-workers, as well as our students, who are also often very stressed out about COVID-19. Okay, I'm going to stop sharing and go back to regular view.
All right, thank you, John. That was excellent. It's touched a lot of things, and it probably has generated a lot of questions for individuals. What I'd ask that you do is, if you do have questions for John, we're not going to go to Q&A right now, but I'd ask you to start submitting those using the chat function within the Zoom meeting here. And when we move into the Q&A session, those already be set on up, and we'll try to, if possible, we'll try to group some questions and do the things that we need to with that. John, you've already given us a little bit of a peek into who the next speaker is, and I see him waiting in his studio, Pastor Adam Miller-Stubendick, who is the intentional interim pastor at St. Paul's Lutheran. I have to say that's the first time I've seen that particular designation. We welcome you. I see, okay, so we welcome you, and we turn the floor on over to you. I don't believe that you could, in good pastoral tradition, do not have PowerPoint, but but are going to be working just with the direct speak to us.
That is correct. Thanks. I want to thank John, Dr. Crane, for inviting me with you all. I serve trying to help congregations through transitions from what was to what is to come, sometimes in the midst of retirement, in the midst of sometimes a crisis moment, whatever the things that call time between clergy, and help them get ready for things. And so I'm now serving a second congregation in the midst of this pandemic, having shifted over to St. Paul's in Williamsville in August. And so now I'm in the midst of, as John said, tomorrow, this weekend, is the first time that St. Paul's will not have an option to gather in person since I've been with them, with this particular congregation. And as was mentioned, I'm a Lutheran clergy person, so I always find it helpful to go to my roots. And so I went back, because I've referenced it a few times. And earlier today, I read a document from almost 500 years ago. So bear with me. And I'm not going to read it because it's long, but it's called Whether One May Flee from a Deadly Plague. It was written by Martin Luther in 1527, as he sought to respond and live in the midst of the pandemics going through Europe nearly 500 years ago. And he said he was brief, but in good Luther form. If you've ever read any Luther, his brief things are long for our world today. So to summarize what he said, and this is what I think helps us all frame ourselves and how we make decisions about being together in person or not. Part of the reason why I've leaned to err on the side of caution if I'm going to err in one way or the other is this is how I would summarize this document. Whatever we do, Do it so that it does not negatively nor adversely affect our neighbor. This is our Christian, and I would argue all faith practices charge in a pandemic. So how do we care for our neighbor is really where this comes down to. Many of you all in healthcare professions, hands-on care for our neighbors. So how can you help others? How can we as people of faith help others to care for their neighbors in the midst of these days? And it's a challenging, not straightforward conversation. Faith in relationship with God is always necessary. And as John referred to a little bit ago, maybe even a heightened awareness of it is happening now because of a pandemic. But how we do that faith in that relationship with God doesn't necessitate we're in the same space at the same time. If we believe it does, how do we navigate caring for our neighbor, which is a core central tenet of all the major faith traditions around the world. I spent a year, sometime as an interfaith chaplain for a little while, which informs some of my work in what I do now. So how do we care for our neighbor is really part of how I land on this. And so at the congregation where I serve, they had already done a lot of great work with John, with Dr. Crane, to talk about how we best set the space up. Anecdotally, the people who were coming to worship were mostly the older end of the demographic of the congregation. And the younger families of the congregation that I have had conversation with, I talk about risk factor. Where do you want to put yourself in your risk factor, whether it's school or work or house of worship? And a lot of the younger people were spending their time on school and spending their time on the workplaces they needed to go to, not necessarily just their time, but their time in a space with other people. And so they were talking more about, they were the ones more likely to do the digital worship and try and be connected in other ways. So so anecdotally it was older people, which caused me pause, because they're the ones who, at least a little bit, says are to a higher degree more at risk. And so how do we care for our neighbor? How do we care for people who it's more challenging for them and for their health to be together, and yet who perhaps their faith says, if the church, if the synagogue, is the mosque is open, it's part of my duty to be there. That's why good Western New Yorkers here, when it comes to snow and blizzards and those sorts of things, there have been congregations that have said, we're always here every week. Even if 5 of us are here and they got here through the blizzard. I say, wait a minute, is that what we want to boast about, that our building is always open? I think it's more important that we boast about how we love God and love our neighbor. The other thing that I've read in a couple spots, and then I'll be stop talking, and I appreciate being this link between John and the next speaker, talking more about how we care for folks mentally and emotionally, which I think is so important in these days. The other thing that I'll say in this vein is, it just left my brain. It was going to come to me. Is how do we as faith leaders, use this moment for good? So I've been saying to colleagues, every house of worship, every faith community needs a really solid reopen plan. Not the short-term reopen for when the pandemic lessens, when we get out of orange and go back to yellow. Sorry, that's my dryer. Not when we get out of orange and go back to yellow, but the full-on reopen when some of the medical challenge and scare of this pandemic has lessened because of vaccine and other things, and we can more fully gather. What do you want your faith community to look like? Do you need to revamp your outreach to your neighborhood? You revamp your outreach to the families connected to your congregation with young children, so that we have a pause in some things we can't do right now. So how do we use this as a pause for long-term strategic planning, so that our faith communities can be more vibrant and look different than they did the day before we started pulling back on March 8th this year. I think that was the last date that I gathered the first time, if you will. So how do we do this stuff well? And how do we make a long-term big plan for when it is safe to get back together? While along the way, checking in with those who can't get out as much, and finding other ways to connect with one another and do worship as well as we can virtually, and with great care for our neighbors in the ways that we do get back together when we're together, just some of us. But my big question is, what do we look like when the vast majority of us feel like we can all be back together? What will our communities be? How will they be knit together? And how might we be called to look different than we did on March 7th, 2020? Those are big different things, but I think they're really important to look at right now.
All right. Thank you very much for those very challenging perspectives. Just a reminder to everybody, with questions for Pastor Miller-Stubendek, put those in using the chat function. We've had some questions already coming on in for John. We have other questions. Let's get those in through there, and we'll be addressing those as we move into the Q&A period. Chris Sullivan, thank you very much. Chris has put in some links to the comments from Martin Luther about fleeing from a deadly plague. So if you want the unabridged version, just click on that. You'll find that in the chat section, and that'll take you right to that. Not now, after the program's over, you can head on out there. All right, John Crane, if you could unmute. The question that's come on in is, if someone has had COVID-19, do they need to get in line to be vaccinated?
I think that they could still take the vaccine if it's offered to them. Remember that initially it will be probably restricted to healthcare workers and frontline responders. But if that applies to you and they offer it, you could still accept it. The reason for doing so is that I don't think you can have too much immunity against this virus. And this might increase the duration of the protection of the vaccine, which is one thing we do not know. We do not know whether this vaccine will protect for a year, which is what some people's guess. That was Tony Fauci's guess, that they would be protected for at least a year. Many people are hoping it would be longer than that, but we don't really know. So getting the vaccine would be fine. And I suspect that as things start to return toward normal, say next summer 2021, you may be required to show proof of vaccination to engage in certain activities. For example, if you wanted to go on a cruise ship, they might require that you show proof of COVID vaccination. And so then you would have it, and you could say, yeah, not only did I have the vaccine, but I also recovered from the infection itself, so I'm double protected. So that's the kind of thing that I would use as my reasoning. So that was a good question.
All right, thank you. So another question that's come on up here that's, well, probably for yourself or anyone else that's participating that may know this, with the vaccines that are being developed, are any of them being studied at this time for use in kids? We've talked about schools and shutting down schools, and it's a big impact on things. What about pediatric vaccines?
Good question. I think that most of the vaccines up until now have been tested in people 18 years of age and over. I would hope that the vaccine companies would begin testing them in children in the spring, even as they're manufacturing vaccine and administering it to adults in widespread ways. I think they should start testing it in children as well.
Okay.
Also in people over 65, because many of the vaccine trials have been people aged 18 to 65.
Okay, good point. I actually didn't realize that they were capping at age 65. I thought they were going up into well, at least into the 70s for both of the leading vaccines.
Oh, okay, that's good. Okay, so they are going higher. Thank you.
So a question this question is mine. one of the things that's come up from the pastor of my church, and that he's hearing things from other pastors and other churches that are all over the map in terms of masking. So some churches are saying, hey, we're maintaining physical distancing. We've blocked out our sanctuary to such a point that everybody's separated by 6 feet, 6-foot gaps between the pews. Pews are closed off, or seats are closed off. How beneficial is it then to tell people when they're sitting there during the service that it's important to stay masked during that? Some places have gone the other extreme. They're only online, right? And so you've got this whole widespread thing of reactions to masking. So what's your recommendation for that?
I think that we should do both. We should do the physical distancing and also continue wearing the masks for those congregations that are doing live in-person services, because the 6-foot distance is kind of arbitrary, and it might not be quite enough depending on the exact airflow patterns in your church sanctuary, which would take a heating and ventilation engineer a year to figure out. And by then people could be sick. So yes, wear the masks even if you're doing the distancing.
Okay. All right, thank you. I see, Leeland, that your mic you're back live with us, but I'm going to go to one last question.
We heard your voice.
Yes. So we have one question here that's a good break point for this. And it is, I appreciate Adam's Luther quote. He went on to say in that same quote that if my neighbor needs me, however, I shall not avoid place or person, but will go freely. In light of the consequences being felt by people from isolation, the kind of things Leeland is talking about, how do you see balancing the two priorities?
Is that to me or is that to Pastor Adam?
That's to Pastor Adam.
Okay.
I really appreciate the question, because that is the conundrum of a life of faith, where we live in the big gray of life, where we do everything we can to care for people holistically. I really appreciated Leeland's the four concentric Venn diagram type circles that was being brought into the conversation. So there are some people are shut-ins who don't have a whole lot of human contact. How do you connect them to a visitation deacon who calls them or becomes a pen pal with them or checks in with them? Or how do you connect? It's about knowing your community to know how to keep people together, while at the same time, I believe, also knowing that there are ways to make worship as good as we can, connection as good as we can. Zoom is not my favorite thing. So tomorrow when we do Zoom check-ins, I'll be like, all right, I'm Zooming, here we go, folks. But it is that both, it's the double edge here of people are feeling it. I've had to call for the first time in 15 years and get county crisis services to someone's house between March and now. So the isolation and the people feeling on their edges is very real. And that's not to be diminished at all, but it's also to say the amount of guilt and things that I think many folks would feel if COVID-19 came to our faith communities and was spread to others through our faith communities. I can't imagine the guilt, not just my own, but also the guilt on the community as a whole and the leaders, the lay leaders who I work with as well.
Ed, you are muted.
Yes, my own medicine. I love it. So what I forgot to share is that tonight's program is being recorded, and you'll have access to this. Some folks have had questions about getting the slides and things like that. You'll have access to the whole program, Q&A and all those things. And that's something that will be, the links to that will be provided after the program today. I am going to cut to some questions. So we have a few that have popped on up. The first couple over here are for John Crane, and the first one is the Pfizer and Moderna vaccines, if they've developed messenger RNA type vaccines, what's the benefit or advantage of this type of vaccine, presumably versus the more traditional forms?
Well, we don't really know whether they're going to turn out to be more efficacious. They turn out to be the first two to report results. We are anticipating results from the other ones. Johnson & Johnson has a vaccine, and also AstraZeneca with Oxford University has its vaccine. They may turn out to be all equally effective. Maybe they're all going to be in the 90 to 95% protection range, which would be very good. Now, one advantage of the messenger RNA vaccine is that you do not have to grow the virus in tissue culture or culture cells and then harvest it and purify the protein out. You also don't have to grow it in eggs like they have done for the influenza vaccine, which is a pretty cumbersome method. They synthesize the messenger RNA using nucleic acid synthesizer machines. One advantage is if the virus begins to show mutations so that in the spike protein, so that it's no longer effectively blocked by the vaccine anymore. With an mRNA vaccine, you can tweak the nucleotide sequence to cover the new strain relatively quickly.
Great. You know, there's a follow-up question to that that's excellent, and that's you described carrying a document that indicates that the vaccination was received, but how long would the immunity last if one were to receive this vaccination, this being the Pfizer or Moderna RNA targeted vaccines?
Well, like I said before, we don't know how long the vaccine protection is going to last. Tony Fauci said that he thinks and hopes that they'll last at least a year. Some people think that they may last much longer than that, and that would certainly be beneficial for us. So we don't know whether we're going to have to be vaccinated again every 5 years, every 10 years, like the tetanus shot, or what. That's still all to be worked out.
Okay, all right, thank you. So as long as you're on a roll here, there's a few other that are very specific to the vaccines. Is the monoclonal antibody treatment called bamlanivimab useful in the treatment of COVID-19? And then I'll let you take that one. There's follow-up.
Yeah, okay, that was the new one. This is the monoclonal antibody that was just given an emergency use authorization this week. It's produced by Eli Lilly. It's a one-time IV infusion, but it's only for outpatients, not for inpatients, and not for people who are already severely ill. It does appear to be somewhat effective. Otherwise, the FDA would not have given it the emergency use authorization. We haven't seen a lot of scientific publications on these products yet, however.
All right, here's one that I'm unfamiliar with. What's the difference between COVID-19 and COVID-21, the latter of which is beginning to present itself in Australia?
Well, I don't know if I can answer that question because I've never heard of COVID-21. And the naming convention is that the last two digits represent the year in which the new viral infection emerged. So if it's already out there, it shouldn't be called COVID-21. It would have to be called COVID-20 because we're still in the year 2020. So that question seems is confusing to me. I think they might be talking about a variant of the COVID-19 virus.
Okay, well, all right, so next one, this is one that I was not expecting because it's directed to me. So can Ed comment on the effectiveness of the combination of hydroxychloroquine, azithromycin, and zinc in the treatment of COVID-19? Sure. There is no evidence that supports the use of this combination being effective, and all the controlled studies that have been done have all of the ones of, I'm not aware of any trials that have been well designed and well conducted that show any benefit for the combination of, well, hydroxychloroquine alone or in any other combinations that are out there. And John, step in and correct me if I'm wrong on that.
Right, yes, hydroxychloroquine with or without azithromycin didn't seem to help in mild disease, it didn't help in moderate disease, and it didn't help in people with more severe disease. So we tested in all different patient groups. And it never showed clearly effective.
And it hasn't shown a benefit as a prophylaxis either for people that are at high risk of exposure, kind of a.
Right, yeah, there were well-done studies of healthcare workers. So taking it prophylactically, if, for example, you're an emergency room doctor or an ICU nurse, that didn't seem to help protect there either.
Yeah, so unlike another established treatment, dexamethasone, which is also an old drug, but seems to have benefit, hydroxychloroquine there are some tantalizing hints that it might be effective, but when it was put to a more rigorous standard, it didn't come through. Didn't come through for us. All right. So those, I think, yeah, no, I'm trying to see if there's any other questions that are popping up here. I think we've hit all the ones. If there are any other questions, if folks want to just type them in via the chat, or if you just want to turn off your muting and unmute yourself, we can kind of bring things through a close. I think I saw David Holmes on the connection. So let's open it up for a few questions, then we can close things down in prayer here, if we could. All right, seeing no last questions that have presented themselves here, I'm going to ask Pastor Miller-Steuben to close us up in prayer for our time this evening.
It's been good to be with you all. In our tradition, we say the Lord be with you and also with you. So the Lord be with you.
And
also with you.
Let us pray. God, we thank you for time together, time to learn and be in community and be challenged and follow you. Thanks for your love that is expressed and shown in the people gathered here. Thank you for the work of the organizations and everyone who is here. And as I'm reminded regularly, you call us to love you and to love one another. And we go forth this night with that charge to love God and love neighbor, mindful that people matter to you and we matter to one another because you created us and called us your own and called us your beloved. So we go forth seeking to follow you, to do your will, to love you, and to respond to your great love for a world in need of a lot right now. Thanks for grace to see us through. In the name of Christ, we pray. Amen.
Amen. Thank you. Thank you all for our participants for just really challenging us with a lot of information this evening. Look for our next program. We're going to be getting back online with our fusion dinners. Except in this version, you supply your own dinner. With some provocative topics, we're going to be releasing our schedule in January. We'll be starting off with some January, February meetings, and moving on from there, hopefully. This meeting is being recorded and all this is being captured, and we'll provide the links for anyone that wishes to be able to catch up on this later on. I've seen some requests for slides for content that's come through, and we'll be able to capture that off the full captured program later on.